Good morning, everyone. Morning. Welcome to Medical Grand Rounds for February 27th. I'm pleased to introduce today's speaker, Dr. Casper, from the Fred Hutchinson Cancer Research Center. Dr. Casper is an associate professor in the Division of Allergy and Infectious Disease and holds adjunct appointments in the Departments of Global Health and Epidemiology as well. He served as the director of the UCI Hutchinson Center Cancer Alliance since 2008, and is also the program head of global oncology and the director of the AIDS-associated malignancies and infectious core at the Hutch. Dr. Casper trained in medicine at UCSF and then did a fellowship in infectious disease and earned his MPH at UW. He's been awarded numerous honors over the years for his research, including a Howard Hughes Medical Institute research fellowship while still in medical school, and Young Investigator Awards from the UW and several other organizations. His research is funded by several ongoing NIH grants and has been instrumental in understanding the pathogenesis of viral-associated malignancies, including Kaposi, Sarcoma, and Castleman's disease. He's continued to investigate both these topics, though has also been studying viral-associated malignancies in Africa for several years, a topic he'll be discussing today in his talk entitled Approaches to Reducing the Global Cancer Burden Through Translational Studies of Infection-Related Malignancies in Uganda. Thank you, Dr. Casper.
Thank you so much. Thanks. Good morning, everyone. This talk is an amalgam of a lot of things that I've been thinking about over the last several years. Many of you, when I say the word Uganda, are probably thinking about some press about the country over the last couple of days, and actually won't be talking too much about that today, but that certainly has been preoccupying my mind. What I will be talking about today is the work that I'm doing at the intersection between infectious disease and cancer. As Mike said, I'm trained in infectious disease, but I feel like I spend most of my time in cancer, to the extent that when you ask my 10-year-old what kind of doctor I am, she says a cancer doctor, and I have to keep correcting her. But my hope is that one day that will matter less, as we really understand that these two fields, infectious disease and oncology, are really very closely related. And what I'd like to talk to you about today is exactly how they're related and how I think that they offer some potential solutions to the cancer burden around the world. First, I should say I don't really have anything to disclose, so we'll just dispense with that quickly. When I came to Seattle, I came here very large in part because I was interested in global health, and this really seemed to be an epicenter for global health. Although I have to say, when I first became interested in the discipline, it was called tropical medicine. That sounds much more glamorous, but global health, being what it is was really the focus when I came to Seattle, and I thought that the best way to study that was through the study of infectious diseases, because my conception at that time was that most of the burden of global health around the world could be attributed to communicable diseases. That's what I was taught in medical school. It's what I was sort of led to believe in the popular press. And I have to say, a couple of years ago, when I came across these data from the Institute for Health Metrics here at the University of Washington, Chris Murray's group, that really tried to quantify the global burden of disease, I was really surprised myself to learn that actually the infectious diseases that for many years I thought were the cornerstones of the burden of global health illnesses still are a significant problem, but actually pale in comparison to other chronic diseases. So this is one way of looking at this big problem, but essentially this is a sort of a quilt of the relative burden that each of these diseases causes in low and middle income countries. And you can see that HIV and tuberculosis is down here on the right, and you can also see that other communicable diseases are that sort of orange quilt. But this block that represents cancer is larger than all of those combined. And the statistic actually says that more people are dying of cancer than HIV, tuberculosis, and malaria combined in low and middle resource settings. Yet it's something that you hear almost nothing about. When I first started working in Uganda in 2004, I met with members of the health ministry, and I asked them why that year, for 10,000 cancer patients and their entire cancer infrastructure for the country, including the hospital, the clinics, and the salaries of all the staff, they spent $50,000, whereas that same year they spent $500 million on HIV. The answer that I got was, we never really realized that cancer was such a problem. So I think that if I leave you with nothing else today, I think I want to leave you with the concept that cancer is an enormous problem in low and middle income countries. And these are regions where there are preciously few solutions for how to deal with them. So anyone who's interested in global health or considering how to make health conditions improve in resource-limited settings, I think really has to begin to consider cancer as the cornerstone of some of those issues. Here's the numbers: 14 million new cancer cases and 8.2 million cancer deaths in 2002. And this graph, I think, is really quite striking. So the number of new cancer cases in developed versus developing countries is really quite striking. So you can see that that cancer is clearly on the rise in developing countries, whereas it's still on the rise in industrialized countries, but not at the same rate. So I would say that these facts together suggest that we really need new solutions for cancer around the world. The other thing that I find really striking is a concept that I've been thinking a lot about called, colloquially, the cancer divide. And unfortunately, what this graph shows, and I'll sort of spell it out in a little bit more detail, but the single greatest predictor of whether or not you will survive cancer is not how great your oncologist is, not how amazing the drugs you have access to or the care delivery system, but it's simply the fact of where you were born. Or I shouldn't say where you were born, but where you come to be treated. So this is a graph that looks at 9 common malignancies and looks at the survival, essentially. So this looks at the ratio of new cancer cases to cancer deaths for 9 different cancers around the world. And what you can see is that for all of these cancers, regardless the sort of winnable cancers that we see here, perhaps versus the ones that are more intractable, what we see is that essentially in a place like a low-income country, for many of these cancers, for every cancer case, there is a cancer death. Whereas in high-income countries, in the best of days, there's only 1 death for every 10 new cancer cases. So this is what we call the cancer divide. And in an ideal scenario, you're still going to see that some cancers are more winnable than others, but this graph would actually look like a straight line. So the different cancers would stack up on top of each other, but it shouldn't matter where you were born or where you live in terms of how likely you are to survive your cancer. So how do we get to this? This is obviously a formidable goal, and me as an infectious disease specialist, you might say, what's your role in all of this? This is from a paper that will come out next month in Nature Reviews Clinical Oncology, where a group of us got together and actually thought about what this looks like. And the takeaway from this is that it's complicated. But when you think about cancer in low-resource settings, what you have to think about is that there are so many limitations. It's not just the resources. The first thing I'll try and convince you of by the end of today is that the biology of many of these cancers that we see is actually different. If the biology is different, then the response to treatment or strategies for prevention also are going to have to be different. But these things have just only been studied at a tiny tip of the iceberg. So the impetus now is that people are trying to take things that we know about cancer in high-resource settings and stamp them into low-resource settings and think that this is going to make a big difference. An example I give is sort of screening for cervical cancer. Cervical cancer is the most common cancer in Sub-Saharan Africa right now. And if you look at the statistics in the United States, they're incredibly, they're something you'd really want to emulate. So essentially a 90% reduction in cervical cancer deaths with the Pap smear. But that doesn't necessarily mean that the Pap smear will be that same tool to get us to a 90% reduction in cervical cancer deaths in Sub-Saharan Africa. We forget that it took 50 years to perfect the Pap smear, and it's still something that is technically quite challenging to perform. And we also forget that in that intervening 50 years, technology has leaped ahead. So there are other ways that are cheaper and perhaps even more easy to detect and screen for cervical cancer. So rather than latch on to techniques that we think worked here, we need to have approaches that are appropriate to the settings in which they're being delivered. So essentially this says that we need to do the research to understand what those things are. We need to build the human and physical capacity, and we need to have an iterative process where we continue to learn. So that sort of distills it down to something that seems like it's a little more manageable. Our approach to this, which I'll describe today, is to form a collaboration with the Uganda Cancer Institute. Now, in addition to all the press that you're seeing about Uganda this week, if you had rewound about 46 years ago, in 1967, the U.S. government actually worked with the Ugandan government to fund and found the Uganda Cancer Institute. And some statistics that you may not be aware of is that this Cancer Institute in Uganda, the photograph is on the left there, was the first place anywhere in the world where combination chemotherapy was delivered for the treatment of cancer. So that's pretty remarkable because at the time they were very interested in a fast-growing tumor called Burkitt's lymphoma. It's had a rich and illustrious history since that time, but it fell on some very hard times. In the 70s and 80s, East African soldiers were barracked in the Cancer Institute trying to overthrow Idi Amin. So you can imagine it would be challenging to run a cancer institute with no resources and with soldiers throwing firebombs in your hallways. But despite all of that, when we started this collaboration with the Cancer Institute in 2004, we felt like it was a great place to begin this work. It's a place where 100 million people, a catchment area of 100 million people, in 2004 went to see a single oncologist and a single nurse. That single oncologist and single nurse saw 10,000 patients a year in a building that had no running water, no electricity, and no roof. So you can imagine that there was formidable challenges, but there were also great opportunities in that, again, every single cancer was seen there. And the other thing that Uganda had going for it is that when it was a British Commonwealth, they established a cancer registry. So since 1954, every cancer case has been counted. Why is that important? Well, it's only one of two places in Sub-Saharan Africa that comprehensively counts cancer cases. And if you're going to try and set up a program that hopefully someday will decrease cancer mortality, you need to be able to count cases. So for those reasons, we started this program, and it's been a long and steady march over the last decade, which I'll describe to you in some detail here. So one question you may ask yourself is, why should you study cancer in Sub-Saharan Africa? And these are some of the reasons that I would suggest. So again, there's efficiency. So now the Cancer Institute is up to seeing 35,000 patients annually. Of those 30,000 patients, more than 90% of them agree to participate in cancer research. I think the latest statistic that I've seen in the US is that 3% of cancer patients agree to participate in cancer research. So clearly there's an efficiency that's gained here. In terms of the biology, I hope I'll convince you by the end of today that the biology of these cancers is different and the phenotypes are more extreme. We were recently reviewing a case that may or may not have been this, but at least was presented as a case of a 13-year-old with widely metastatic triple-negative breast cancer. Now, again, I'm not an oncologist, but I would think that that would sort of sit on the tail end of the extreme of what is seen in terms of breast cancer cases in the United States. But actually, young women with triple-negative breast cancer are the most common presentation that you see in Sub-Saharan Africa. So why is that? If you can understand that phenotype, you can understand the biology of the diseases much better. Again, the natural history and the response to therapy may be different. And the final thing is something that was a term that was actually coined by some investigators at Duke, which is a term called reverse innovation. You know, at this point, the way we do cancer research in the United States, it really isn't feasible to begin to ask those questions of whether we're doing too much. So an example I like to cite is Burkitt's lymphoma. It's a disease where here in the United States, a child with Burkitt's lymphoma has a 95% chance of a cure. But if you ask an oncologist what's the cornerstone of treating Burkitt's lymphoma, it's to hit hard and to hit almost with an atom bomb up front, because when that disease relapses, there are very few options for its treatment. The fact is that probably every child who has this disease doesn't need to be hit as hard as they are. But it's very hard to design a study in which you give therapy that's not designed to be as strong here in the United States. If you take a setting like Uganda, where right now you're working from a platform of almost no treatment, you can begin to work your way up. And hopefully through that process, you can develop tools, biomarkers, other things that begin to explore when it's appropriate to dial down therapy here in the United States. So we believe that that's an example of reverse innovation, looking at combinations of older drugs to see if they can be as effective as newer drugs. This is the reverse innovation you might expect to see. There are also reasons why I would say you shouldn't do cancer research in Sub-Saharan Africa. There are many of them, and they keep me up most nights. Efficiency, we have at least 5 regulatory bodies that has to review every single study that we do. Comments that we frequently get are that we misspelled a verb or that we spelled it wrong, and that sets the study back 9 months. So, this is not, it's not something to be taken lightly. Expatriating biospecimens is a touchy issue. When is that appropriate? And who owns the specimens that are collected in another country? The cost is also something that I never came to realize. Cancer research is incredibly subsidized here in the United States at our cancer centers by funds from the National Cancer Institute, which help those centers operate. None of that currently exists in places that are very resource limited. The capacity, so again, there are, as I said, there was one oncologist in the entire country of Uganda in 2004 who was also responsible, in addition to seeing patients, to writing the National Cancer Care Policy and educating all of the healthcare workers in the country. How do you partner with that person to do research? That's very challenging. The physical infrastructure is limited, and of course, there's ethics, right? So is it ethical or is it justifiable to sit there and do cancer research in a setting where every patient coming for cancer care is dying? And what do you do about that? So these are some of the things where there are some real challenges, but I would like to submit to you that I believe that the benefits outweigh the challenges, and hopefully at the end of this talk today, you'll agree with me. NIH is certainly also beginning to agree with this. These are two of the former director, or one current and one former director of NCI, who have both come around to the thought that really the only way we're going to make meaningful progress in cancer research is to study abroad. So again, I think that there is support for this concept. So with that as a background, I hope I've convinced you that cancer is an important global health issue, and that it's one that really is crying out for new solutions. And the question is, how do we address that? And the question you may be asking me is, how, as an infectious disease specialist, do you hope to answer these? And so that's what I'll tell you now. So this is an incredibly bewildering graph. It's a pie chart that looks at the distribution of cancers in East Africa. This is based on cancer registry data. As I said before, whenever you look at data from East Africa or from Africa in general on cancer, you have to recognize that the cancer trends in 1 billion people are being inferred from 2 cancer registries that cover a population of 6 million people. So you're making inferences on 99% of the population from less than 1% of the population. Even if you're not a biostatistician, you recognize that that's a tenuous position to be in. But that being the case, if you drill down to East Africa, where I believe the data are more accurate, although again, the overwhelming majority of cancer cases don't come to medical attention. People die at home or that they're inaccurately diagnosed. All of those caveats as aside, if you count the cancer cases as they're currently being counted, this is what you see. So there's a wide rainbow of types of cancers that you see in East Africa. When I look at it this way, you may not discern any patterns. But when I show it to you this way, 60% of the cancers that you see in Uganda and in the rest of East Africa are related to an infectious disease, whereas 42% aren't. Now, this is my diagram to remind me that, again, as an infectious disease specialist, to a hammer, everything looks like a nail. And so for me, I look at this and say, wow, there's a lot of cancers that could be related to infectious diseases. What an opportunity there. So this is one of the reasons why we are working in Uganda and in East Africa. This is a magazine that was given to me by a friend and a colleague who I work with. I call this the most overlooked story in the popular press. So on the left is the new evidence that cancer may be infectious. This is from 1963, Life magazine. And on the right, skinny dip of Marilyn Monroe, pictures you'll never see. So I can tell you that when I look at this, I spend a little bit more time looking at the infection-related cancers, but the rest of the magazine is also worth looking at. My point to say is that this is not a new concept, that infections cause cancer. But perhaps because of this, or perhaps because of other reasons, it tends to be overlooked. You may know we have a relatively new director of the Hutchinson Center, and when we were interviewing for that position, one of the other candidates, who shall remain nameless, asked me what I do, and I said, well, I work on infection-related cancers, and this very esteemed oncologist looked at me and said, infections cause cancer, and I thought, wow, we have a lot of work to be doing here. So maybe this was part of the reason, but nonetheless, if you look around the world, about 25% of cancers are caused by an infectious disease. And this is the way I tend to think about the etiologies of cancer. So about a quarter are caused by infectious diseases, about a quarter are caused by genetics, about a quarter by your environment used loosely, and about a quarter we have absolutely no idea what causes these cancers. Now, again, I'm fully aware that this is a biased perspective, but what I would submit to you is that when you look at these causes of cancer, for 75% of them, there's not a whole lot you can do right now about them. You can understand the biology, you can infer that someone may have an increased risk of cancer, but there's very little you can do about a genetic mutation that leads to cancer at this point. I'm not saying it shouldn't be something that we study or that deserves further work, but at this point, of these 4 causes of cancer, infections are something that I firmly believe we can tackle now and reduce our cancer burden around the world by at least a quarter by focusing on infection-related cancers. And again, there are estimates that say if every child at birth was vaccinated against hepatitis B around the world, the overall cancer incidence in the world would drop by 20%. It's pretty remarkable. So that suggests that if you can sort of extend that thinking to other infectious pathogens, you could make a very meaningful difference on cancer incidence and mortality within our lifetimes. And that's where I get very excited. And that's where I think I may be able to contribute something to the cancer burden as an infectious disease specialist. This is another cartoon I love to show from my favorite medical journal, The New Yorker, and it says, don't just stand there looking precancerous. And to me, this is the challenge especially when you work in climates where people have darker pigmented skin, it's not so easy to look at someone and say, hey, you look like you're precancerous. So how do you develop something that actually can tell someone that they look precancerous and that you can actually do something about it? You can put up the sunshade or put on the sunscreen, so to speak. So again, in my sort of simple mind, the way I think about this is that when you're working on infection-related cancers, you don't have to be so smart. There's essentially a long pathway and many steps along that pathway where you can intervene to try and make meaningful differences in the incidence or the treatment of cancer. You have ways to prevent primary infection, ways to study the infection as it sets up a chronic replicative state, and then finally ways to deal with the infection as it progresses to the malignancy, and maybe even target that infection as part of treatment for the malignancy to make that less toxic and more effective. So these are some of the central questions that we're trying to answer through our work in Uganda. How are infections which cause cancer transmitted and acquired? And we do these through studies I'll describe to you, which are primary infection studies. We look at kids from the time that they're born, and we look at how they acquire oncogenic viral infections and look to see what the natural history is. We follow these kids over time and look at how the virus and the immune system interplays with each other. We then try and develop biomarkers to see, well, can you predict or maybe in some ways prevent these cancers? Can you develop new treatments for these cancers? And are there novel risk factors for cancer that we can gain by studying cancer in other settings? So I'll go through some of the research now with that all by way of background. So Uganda, in addition to everything else you're reading about it, has another distinction, which is that it has the highest fertility rate. And the hospital that we work at in Uganda has the largest number of daily live births anywhere in the world. So that seemed like something to be capitalized on. There are 1,800 kids that are born each day at this hospital in Uganda, which seems absolutely amazing. But what we decided to do was take a small subset of those, and we went to the maternal clinics and enrolled in the antenatal clinics mothers as they were getting ready to give birth. And we collected specimens from that mother prior to delivery and then attended the birth with that child and followed that infant and their family along for up to 5 years with weekly visits at home where we collected samples and did questionnaires on these family units every day. It wound up being a somewhat small study because it was so intensive. We screened about 300 people for the study. We enrolled about 120, which wound up to be about close to 40 family units. And that was what we wound up doing for the study. But the results have turned out to just continue to be fascinating. So this is a cumulative incidence graph of these viruses that we looked for. We essentially looked for acquisition of any DNA virus, and you may ask why, and the answer is because we can. You may well know that here at the University of Washington in our diagnostic virology laboratory, we run assays for 14 DNA viruses. So we looked at all of them. We were specifically interested in the oncogenic viruses, so those would be HHV8, EBV, and HPV. But I'll talk right now about the herpes viruses as a family. So this is a cumulative incidence graph, and you, again, don't have to be a biostatistician to figure out that essentially by 2 years of age, every single child had acquired every single herpes virus except for HHV8. Now, that's very interesting. If you look at this in the United States, it's very, very different. So again, for some of these viruses, even by adulthood, only a quarter of individuals acquire these viruses. But more than that, they acquire them over the course of a lifetime, not all in the first 2 years of life. So what are the ramifications of being hit, essentially, with 14 different viruses in the first 2 years of your life? How do you even begin to handle that? How does your immune system begin to structure itself to control this? And what are the long-term ramifications for this? And so these are some of the questions that we're beginning to ask. So one of the things that we also found in doing this work is that no one has really very meticulously characterized what primary infection with these viruses looks like in kids. So if you would ask me a priori, what would infection with EBV look like in kids, I would have said this. So this is a graph where, again, the primary child is followed by month, and the circles represent quantity of virus, EBV, which is found in saliva. So again, up until about 6 months of age, there's no virus found in saliva. And again, my traditional teaching in medical school would have told me that this is because there are maternal neutralizing antibodies that protect against the acquisition of EBV. Indeed, this child is seronegative, as indicated by the negative signs. And then right at about 5 months of age, you see this spike, where on a given day, we find it's actually close to 1 billion copies of EBV in saliva. And then from that time, the amount of virus in saliva decreases slowly, and the child seroconverts. So this is what I would have been expecting for a typical primary viral infection in most of these kids. It's not what we actually saw. So what we saw was actually more like something like this. These kids, from the first year of life, have repeated episodes where you can detect virus in high quantities, up to 10,000 copies in saliva, repeatedly with no evidence that they've seroconverted or that they've seen these viral infections more broadly. And then there seems to be a take under which the virus takes off. So what does this mean? What is the impact of having this localized infection? It seems like an oral infection with these viruses that don't disseminate so early. Not very clear, but studying the immunology of that early period, we think that there's interesting things to be gained. The first thing that we're beginning to learn, and I'll show you these data in a moment, is that the viral strain may be adapted in these early months to only infecting epithelial cells, so it isn't actually able to disseminate throughout the body. The second thing we're beginning to learn is that the role of maternal antibodies is probably less prominent than we think, especially in HIV-infected mothers who have lower quantities of these antibodies, but that there are other innate cellular immunity that probably are preventing an established infection from occurring here. So understanding those, we think, will be very important. This is a crazy graph, but if you look at it, this is how much virus is detected in saliva by week by every member in this 7-member family. And what you can see is it's crazy. I mean, the cumulative exposure to a virus, there's like hundreds of billions of copies of EBV that are floating around in this household on a daily basis. So when you look at this, you may say to me, well, if you really want to study how these viruses are transmitted and acquired, how could you possibly do this? This is a morass. How could you figure out who gave what to whom? And I would somewhat agree with you. But what I would say is that we're starting now to do more sophisticated work. So we've actually done some of the first whole genome sequencing of EBV isolates. And what we're able to find is that you can see patterns. So for instance, on the bottom is a pattern where a sibling and an infant have the exact same EBV genome. On the top, you see situations where, again, that's different from the mother in that family, but similar to other families. So again, we believe that using whole genome approaches to looking at these viruses will allow us to figure out the molecular epidemiology to a detail that never was thought to be possible before. There's also ways you can model this more traditionally, and we have some fancy mathematical models, but even just basic models of looking at risk factors for acquisition. Here you can see that the strongest risk factor for acquisition in these families is whether or not the mom has HIV. And when you dig deeper into that, you find that in those families, the mom makes very poor neutralizing antibodies, so those are poorly passed to the child. And you also find that she's shedding virus at titers that are much higher than in any other situation. So again, all of these things together, we think will be the real first conclusive evidence for these 14 different DNA viruses, including 3 oncogenic viruses, about how they're transmitted and acquired. And we're very excited about this work. The other thing we find is that kids really vary in how they control these infections after they're acquired. So we know that having persistent EBV or HHV8 in your peripheral blood is one of the strongest risk factors for the development of their related malignancies. Most of us, after we have EBV, very well control it and don't have the virus frequently detected in our peripheral blood. But in those who don't, those are the folks we think are at highest risk of going on to develop lymphoma, and we know that in HIV-infected cohorts and transplant cohorts. Well, here what we see are sort of 4 different phenotypes of children in Kenya. And on the right, we see that children born to HIV-positive mothers are unable to control their EBV in their peripheral blood after primary infection. Now, in this cohort, 60% of the HIV-positive kids born to HIV-positive mothers died before 2 years of age. This is an older cohort. Now, as we're beginning to treat HIV better in these children are living longer. What's interesting is that we find, and there was another paper that was published last month in CID, that actually even these kids, when they're treated, poorly control EBV infection, and that control actually depends on the drug regimen that they're on for their HIV infection, where children on protease inhibitors control these infections much better than children not on protease inhibitors. So what this says to me is that while in the past we haven't seen explosions of pediatric lymphomas in East Africa, simply because kids with HIV weren't living long enough, now that they are living longer, we may see a legacy of pediatric lymphomas that we hadn't previously recognized. So again, we think that this work is interesting for those reasons. I won't summarize this in the interest of time. And now I want to go from data that looks at primary acquisition of these viruses to this next thing. So one question that I'm fascinated with is if I look around this room, 90% of you are infected with at least one virus which could cause cancer. My hope is that less than 1% of you will ever develop cancer from that virus. So what's going on with that? Why is it that there's this discrepancy, and why do some individuals who have these oncogenic viruses go on to develop malignancy? And again, and that's my tip of the iceberg diagram. Given that, in my simple mind, I think that there are 4 possible reasons. There could be something different from my virus versus your virus. There could be something different about me as a host versus you as a host, or there could be something different about our environments. I also acknowledge there's probably a whole other set of things that I'm not smart enough to think about, but certainly could be part of this process as well. So how do you begin to decipher that? And so I'll go back to some studies that we've done, again, of HHV8, both in Seattle and in Uganda, to look at this as a model. And what we find, this graph on the left is a complicated graph, but if you look at individuals who are seropositive for HHV8 infection, they vary widely as to how frequently you find the virus in saliva and in the blood. So people really vary in how well they control this virus. Again, we know that the control of that virus is probably the strongest risk factor for eventually going on to develop the malignancy. So what governs the control of viral replication? Well, we're not sure, but this was a really interesting study we did. So Uganda does a serosurvey where they go out and try and measure HIV and hepatitis prevalence in households across the country. And we had access to those 20,000 families and blood specimens, and we tested them just to see whether or not they had HHV8 detectable in the peripheral blood. Again, if I did that in this room, well, it would be zero because so few of you are infected with HHV8. But even in Uganda, where 80% of the population is infected with this virus, you would think it would be unusual to find the virus in the peripheral blood. Most people would control it. And indeed, that's what we found. But what we found was there were pockets of Uganda that clustered geographically where there were people who were unable to control viral replication, that the virus was found in high quantities in this random serosurvey of healthy individuals. And when we superimposed the prevalence of detecting the virus in blood with the prevalence of KS in those communities, even before the HIV epidemic confounded this, we found that the graphs completely overlapped. Well, they didn't completely overlap because Uganda redistricted, just like we do every few years, but if you were to keep the maps the same, it looks like there is almost complete overlap. So this to us suggests that there could be environmental, but more likely genetic factors which play a role in the control of these viral infections. Uganda has 56 tribes. They're very closely, I wouldn't say inbred, but it was relatively unusual to marry outside of your tribe. So there's probably a lot of genetic integrity within each of these tribes. And you could therefore think that that might be one of the reasons that the genetics could govern the control of these infections. And indeed, this graph is a mess, but what we began to do was work with Effie Petersdorf, who does all of the HLA and KIR typing for transplant at the Hutch. And we asked her to say, well, what are we seeing in terms of HLA allele distribution, and how does that relate to the control of viral replication? Bottom line is that we have a lot of work to do in terms of the analyses here, but even in just looking at the first 25 families, Effie's group found 3 completely new alleles that have never been described before in the HLA and KIR region. This suggests that, again, as we all know, there's a tremendous amount of genetic diversity seen in this part of Sub-Saharan Africa. But more than that, it also suggests that this diversity may be correlated with the control of these viral infections. And when you look at each of these alleles among people who control virus and who doesn't, there are really striking differences. Now, any of you who have done genetic studies would know that the sample size needs to be much larger than the 200 individuals that were in this study to make important inferences. But what we can do is go back and understand the function of some of these alleles and try and make intelligent guesses as to why they would or would not be important in the control of replication and design more specific and larger studies, and that's what's currently underway. The other thing that we can do with these cohorts is try to identify, as we watch people over time, who are these people that are not controlling viral replication well, or who are these people that we actually can observe go on to develop cancer. And again, when we do this work in our KS cohorts, we've actually been able to use proteomics and tandem mass spec to identify blood and plasma markers that suggest that people are at higher risk of going on to develop these malignancies. This is a crazy map again. I'm sorry for showing all of these crazy pictures, but this really shows that of the 12 proteins that we were able to identify that seem to be specifically associated with the development of KS, they all seem to map back to the interferon gamma pathway, and that is biologically plausible because we know that this is a very important pathway for the control of viral infections. What this means now is that we can develop blood-based biomarkers and test their performance, and what I think is really neat about this is that now we actually have an intervention which could prevent the development of these cancers. Again, I won't go into great detail about this, but Soren Gant, who is one of our collaborators who's now at UBC, pediatric infectious disease specialist, began to look at antiretroviral drugs and their effect on viral oncogens. And the reason he was interested in this is that we all probably know that the incidence of cancer in HIV-infected individuals dropped about tenfold once we started using highly active antiretroviral therapy. We don't know exactly why that is. Most people have been thinking that that's because the immune system is reconstituted, but we also think there's a direct effect of these drugs. And indeed, what Soren found was that protease inhibitors, specifically an older one called melphinavir, has a profound effect on these viral infections. Essentially, it causes the viruses to get locked within the endoplasmic reticulum and induce autophagy, so that these viruses are trapped and destroyed before they can exit the cell. Melphinavir does this quite well. Lopinavir, ritonavir does it to some extent. But the thought is that then, if this could be a potential mechanism or an antiviral mechanism, and also as a key component of HIV therapy, could you design a therapy in which you could use our protein-based biomarkers to identify individuals at high risk of developing cancer and use a chemopreventative approach? And indeed, there's a study which is about to be put out into the field in 4 sub-Saharan African countries in collaboration with the AIDS Malignancy Consortium to do just this, which is essentially to add melphinavir to a backbone of standard antiretroviral therapy and see if we can both control viral replication and prevent the development of malignancies. So again, this is where I see the promise of this work, which is that you can actually not just sit there and observe something you know to be true, but potentially make an intervention by which you can prevent the development of cancer. The other clear way that you could do this is through the development of vaccines. And I would say that there's 2 targets which are very ripe for plucking. Everyone's talking about HPV, and I'm not here to tell you that that's not an incredibly important thing to do, but it can't just end there. As I mentioned before, hepatitis B is a really important issue that needs to be, yes, we could sort of try and cry for universal vaccination at birth, and we may get there, but it's actually interesting to think about other applications of this as well. In Uganda right now, HIV-infected individuals are not recommended to be vaccinated against hepatitis B because the thought is that they would have already acquired it in infancy in a region like Uganda. Turns out we've actually found out that the incidence of hepatitis B in HIV-infected individuals is quite high and would justify a vaccination program, and we're trying to do a study right now to show that. But the other thing that I'm very excited about is a potential vaccine against Epstein-Barr virus. Many of you may know that there was a vaccine that was developed by GSK. It was tested in the early 1980s. It actually worked in reducing symptomatic mono, but it didn't work in sterilizing immunity. It didn't prevent infection. And the vaccine was eventually shelved because it was thought that there would be no market for it. But the question of whether that vaccine could be sterilizing, if not given in adolescence, but rather given in infancy, and the question of whether or not, even if it weren't sterilizing, could it prevent the development of cancer, I think is an interesting question and one that we'll start to study. Finally, I want to just tell you that I think that the other thing that's really exciting is the concept that we haven't yet identified all of the pathogens that are responsible for cancer. There are several malignancies which are increased incidence in immunosuppressed individuals: lung cancer, lip cancer, squamous cell carcinoma of the conjunctiva, and non-EBV-related lymphomas. That right now, because they're at such high incidence in immunosuppressed individuals, it would suggest that they could be attributable to a viral infection, but no viral etiology has been found to date. So I have a project with Denise Galloway and Margaret Madeline at the Hutch, where we're actually looking at specimens of individuals who are immunosuppressed, who've developed these common cancers, and we're using tumor genomics and whole genome sequencing to try and identify novel pathogens. I can tell you right now, the only thing we found is a whole lot of plant viruses. Not really sure what that means. Maybe they could be the cause of cancer, or maybe people were just eating plant products. What those were doing in tumors, I'm not sure. So a lot of work to be done, and this is a difficult field to sort of pursue. But nonetheless, I think it's certainly a provocative question. I want to, with the last few moments, turn a little bit to some of the clinical manifestations of cancer in Uganda. This is my slide, and I'm sorry for showing it so close to breakfast, but this is my slide of what I call things you don't see in Seattle. On the left is a child with widely disseminated Kaposi sarcoma. I've never seen that here in Seattle. In the middle is a form of Kaposi sarcoma that, again, we don't see here, called fungating KS, which is one of the most common forms of this cancer in Uganda. And on the right is actually a woman with KS, which is also vanishingly rare here in the United States. These are 2 children on the bottom with Burkitt's lymphoma, again, a very common cancer in Uganda, but the manifestations of this disease in the United States rarely look like this. The sporadic form is quite different. So that begs the question of why do these cancers look different? And let me just introduce the concept in the interest of time to say that when you look at that tumor on the left, which is nodular Kaposi sarcoma, and that tumor on the right, which is macular Kaposi sarcoma, Again, small kids on the street could tell you that those are different, but the reason why they're different is an interesting question. And so what we've begun to do is biopsy those lesions and look at their genome to try and understand what the host and what the virus is doing. What we find is that those tumors that are on the right, these macular tumors, have an incredible amount of active viral replication in them, where the ones on the left seem to be more burned out and don't have a lot of active viral replication. And again, when we look more closely at this and we plot these out using, again, genetic methods for whole genome analysis, we find that these tumors cluster based on their morphologic appearance. And so that to us suggests that we can understand the biology of what causes these aggressive forms of Kaposis and begin to target those pathways with specific interventions. This same process we're doing for other malignancies, cervical cancer, breast cancer, lung cancer, and we believe that we can find phenotypes of the more aggressive cancers and understand what makes them more aggressive. That's exactly what these projects are aimed at, and a new collaboration with NCI's Office of Tumor Genomics is contributing over 400 specimens to that tumor genome atlas to begin to look at differences of cancer in these regions. In the last couple of minutes, I just want to turn to the issue of care. This is really something that's quite striking to me. Again, working in an environment where every single patient with cancer dies is not feasible, and again, we need to think of ways to improve this situation for the cancer burden around the world. So the first thing that we've done is, again, I mentioned to you that there was one oncologist in the entire country of Uganda, and that's really a non-starter. You know, there's really not many interventions you can do with a single oncologist in the entire country. So we started a training program here with our colleagues at the university and at the Hutchinson Center. Many of you may have met some of our Ugandan trainees who have been here. We've trained 16 oncologists, so 12 primary oncologists and 4 other specialists through rotations. You can see here, here's Dr. Mutiaba and Dr. Okuku, with Ali Press and myself over at the HCCA, and a very kind patient who was excited to meet all of us. Dr. Mwaka with Dr. Graylow, and then our most recent cohort of fellows with us. So, this capacity building has been extraordinary. In addition to 16 oncologists, there's now 300 healthcare workers and researchers who we have trained in the last 10 years, who all now are on the ground, all back in Uganda, and all are sort of taking up arms against cancer. This actually gives you a cadre of people, of individuals, in which you can begin to address some questions or some solutions. Prior to this, there wasn't much you could do. So then what do? Well, then you need to build the clinical care capacity. Again, working in an environment where there's no running water, no electricity, and no roof is the non-starter as well. And so with these new teams of healthcare workers, we've developed guidelines for the comprehensive treatment of the most common cancers, and we're looking to see whether or not those guidelines can be effective in improving their care. We also now have conferences by which we try and improve educational opportunities. And finally, we have a new building, which we're very excited about. So this is our new center, which will open at the end of this year. This will care for 35,000 outpatients a year. We'll have a top floor set of laboratories which will support all of the diagnostic care, but also all of the research. And the second floor is a training facility. So we believe that this is a center of excellence that will serve as a model for this type of work for Sub-Saharan Africa. We've had a demonstration project with Burkitt's lymphoma where we've really tried to address this particular malignancy. And what I can tell you is that we found that there are so many challenges to good cancer care. I've listed them here, but everything from even identifying cases early enough, 90% of these kids are coming with advanced stage disease. There's so little you can do even from that starting point. So identifying kids earlier, getting them accurately diagnosed and treated on a care pathway, these are all the components of what we're trying to do. In a one-year period, we put 125 kids into this pathway. The first thing we found is that 30% of kids referred to us with a diagnosis of Burkitt's lymphoma didn't even have it, so we had to work on that. But what I can say is at the end of all of this, we've taken a disease that had about a 30% one-year overall survival, and it's now about 60%. Again, it's not great. I mean, a child here has a 95% chance of cure, so that's a huge cancer divide we still have to bridge. But I think that by putting a care team on this and by thinking about it comprehensively, there may be a way in which we can improve cancer even without doing anything new or fancy. All of this, we've figured out, costs about $1,800 per patient. Another thing I hear is it's too expensive to treat cancer in low-resource settings. That's expensive, but it actually is it's actually the exact same price as treating a case of drug-resistant tuberculosis, and I've never heard anyone make an argument that that's not a cost-effective intervention. And again, in a model that Chris Murray had done, treating childhood lymphoma was the most common, second most cost-effective healthcare intervention in the UK, and that was when it was thought to cost $105,000. $100,000. So to me, this seems like a bargain. I want to stop there and leave some time for questions. I, of course, want to make sure I thank all of my collaborators in Uganda as well as here in Seattle and our funders. And I hope that through this talk, I've given you at least a little bit of background as to why cancer is such an important global health issue, and perhaps why focusing on cancers as they relate to infectious diseases may offer a promising solution to cancers, not just in resource-limited settings, but also back here in the United States. So thank you for your time this morning.
Very nice job. It's really amazing what you've done, and that cost per patient of $1,800 is just incredible. The thing I was fascinated by the difference in the EBV viremia in children, and I remember the association of EBV-related cancers and malaria, and I wonder if you've looked at closing the gap there, trying to understand why that might be the case.
Yeah, thanks, Wes. So I'll repeat the question for those listening at home, which is what's the relationship between malaria and perhaps EBV-related malignancies? And certainly for many years, we know that the incidence of Burkitt's lymphoma in Sub-Saharan Africa is significantly elevated in areas where there's a high malarial burden. And there's even one study which has come to be debunked a little bit, but with mass malaria, bed nets and spraying, that maybe the incidence of Burkitt's lymphoma dropped in Tanzania when this was done. Although, again, in relooking at that data, not so clear. So the question is, what's the relationship? And I'll tell you two things I've learned. So one is that I've done this project with NCI where I've looked at Burkitt's lymphoma around the world, and a huge hotspot I found for endemic Burkitt's lymphoma is actually in northern Morocco. It's in the middle of the desert, and I can tell you there's no malaria there. So to me, that suggests that malaria is clearly an important cofactor, but is not necessary. So, it's not sufficient, not necessary, but maybe an important cofactor. I think that biologically, there's a lot of ways that it's plausible through the rearrangement of B cells and the chronic antigenic stimulation. But I think that we really need to understand more about that. Some of the work that we've done, I didn't present these data, but we did an interesting study. We have collaborators in Tororo in Uganda, where on average kids get 9 malarial episodes a year. And so these kids are followed during their malarial episodes and randomized to one of 2 different antimalarial regimens. And we looked at this cohort to look at what was the relationship between parasitemia and EBV or KSHV replication. And indeed, there is a significant relationship. So when kids are parasitemic and febrile, the quantities of these viruses go up significantly. Interestingly, they don't seem to drop that much with at least the initial days of treatment. But again, a lot of these kids are getting artemisins and the duration of therapy is low. So I think clearly in my mind, the malarial co-infection probably increases replication of many of these oncogenic viruses. I think it causes, again, this rearrangement, that could, again, lead to somatic mutations leading to cancer. So I think there's an important link. I guess we really need to understand more about how that link works and what's happening in these cases of endemic or other diseases where there is an association, but not an association all the time. Hi, Pam, yeah. Oh, sorry.
Corey, that was fantastic.
Thank you.
I have 2 questions. First of all, one of the other differences between what we see in low and middle income countries, especially places like Uganda and here, is that the family unit often is not just the human family, there's the animal livestock family. And one of the things we've started to look at with respect to some other things is how exposures in the kind of One Health, through the One Health lens, looking at the family more broadly writ, might change what pathogens, including viruses, an individual is exposed to, and then related to that, what happens with the dermal, GI, and genital microbiome.
Yeah.
And I'm curious whether, in relation to your work on cancers in Uganda, you've been thinking about any of that and how you've been moving in that direction. And then the second question is, you didn't mention hepatitis C. Mm-hmm. And given that we're on the verge of curative therapies for hepatitis C, I'd be very interested in what you think about hepatitis C and liver cancer in the African context in which we have much more sparse data on prevalence?
Yeah, thanks for your question. So two very good and complicated questions. I guess let me answer your first one first, which was how do we think about the sort of total burden of infections that are within a family? And again, maybe that comes from, the close proximity to animals or different sort of, agrarian lifestyle. And also, how does the microbiome affect, and I would say perhaps the virome as well, affect the incidence of these cancers? These are great questions. I guess what I'm beginning to learn are a few things. So first of all, the state of cancer research, again, I sort of look at a lot of this through the lens of HIV research in Sub-Saharan Africa. And this is kind of my abridged and totally biased version of HIV research in Sub-Saharan Africa. But I think initially there were a lot of sort of low-tech, epidemiologic, Me Too type studies, right? Like, the first studies of HIV in Uganda found, hey, guess what? Actually having a CD4 count of below 200 predisposes you to an opportunistic infection. Like, why would we expect that to be any different? But that was what the capacity was to do a study at that time. You could measure CD4 counts, you could measure opportunistic infections, and that's the first studies that were done. Now the studies are much more sophisticated. I mean, the studies that are being done in Sub-Saharan Africa of HIV have informed our care of HIV in this country as well as our prevention. So HIV has really evolved to more sophisticated research in Sub-Saharan Africa. Cancer's not there yet. So to answer that question about what is the contribution of the environment, of different exposures within the family to cancer burden, you really need to sort of think about these questions in a way that's very different. The literature is replete with studies that say if you own one cow but 2 goats, you have an increased risk of KS. Well, what are you actually measuring in an epidemiologic study when someone has 2 goats but not a cow? I don't know. I mean, maybe that's a socioeconomic status. So the quality of the epidemiologic research at this point for cancer is very crude. More than that, there's not really a good biologic hypothesis to even guide how you would sort of do epidemiologic studies. So then that points to, okay, well, what types of studies, if you were to do sophisticated studies, what would you bring? So would you look at the microbiome? And of course, that's incredibly enticing, but how do you even begin to look at it? I mean, right now I'm sort of looking at the microbiome and thinking, my goodness, like it is such a complicated unit. How do you analyze that? So I think my answer to you is that it's undoubtable to me that, so much of the cancer burden is in regions where there are atraditional exposures, different members of, family units, different practices for KS. To your point, one of the strongest risk factors is probably mothers pre-masticating food and transmitting viruses to children that way. But again, how would you even think to answer that question or ask that question if you didn't know that that was a practice? So we need to do so much more baseline, ground level work, 1, to develop the infrastructure, and 2, to think about intelligent ways to answer these questions with directed hypotheses. But I have no doubt that what you're referring to plays important roles. I hope that some of the pathogen discovery work that we're doing, where we actually will quantify and qualify the virome, at least, will help us to understand, okay, well, there are these plant viruses. Maybe they're not the cause of cancer, but what are they doing? There are these animal viruses that we're seeing. What's their role in this process? So for viruses, I think we'll begin to get a handle on that. For the microbiome, I think we need to, but we're still very much in our infancy. So non-answer, but essentially telling you that I think we need more infrastructure and more baseline information to guide those studies. Hepatitis C is a really important issue, no doubt. In Uganda, it's not that important of an issue. It's a relatively uncommon cause of liver cancer in East Africa. I think that where there are real opportunities, as you say, for treatment, perhaps for prevention, and I think where there is, again, something that really needs to be studied is how do multiple risk factors combine for the development of hepatocellular carcinoma. So in West Africa, liver cancer is incredibly common. Part of that is because of hepatitis C, but a lot of that is because of aflatoxin exposure. And in this country, we don't have any thoughts about how aflatoxin exposure and hepatitis C work together. Again, biologically, we understand how it's plausible, but how that works on an intervention level and what we do about that, that's, again, it really points to this discipline and why we need new solutions and new thoughts. So clearly a big problem. I think getting treatment to people who need it will certainly reduce liver cancer. We know that. But how to think about that in a way, a vaccine for hepatitis C, that would be lovely. But how do we think about this in a way where we understand comprehensively the biology of the disease to make important prevention strategies? It's really important to do.
Corey, that was just magnificent.
Thanks, Pam.
Congratulations on that work. I was interested in the genomics of the viral-related cancers, where we're gathering more and more information about so many mutations, cumulative mutations involved in each cancer and the unique cancers. And my question is, when there's a viral etiology, what's the relationship between those mutations versus mutations in the same diagnosis but without a clear viral etiology? And are there just more mutations, or are they in the same genes, and that kind of relation?
Yeah, thanks for your question, Pam. So I guess the question is, how do mutations within the tumor relate to things that may be induced by viral infection? So a couple of answers there. So again, starting at the ground level, I think what's really interesting is if you look at the Tumor Genome Atlas project, which in my mind has had some fascinating observations, and other whole genome studies of lymphoma and leukemia, one of the first things you do is you look at the genomes and you throw out anything that's not the human genome, right? That's kind of the basic method of analysis for these cohorts. Well, that's throwing out a tremendous amount of data. It's actually the data I'm interested in. So, we first have to all get together and say, wait a minute, let's look at all of the information we have available, because that's the only way we're going to understand the relationship between the human genome and, again, the infectious genome that may be sort of interacting. So we're just starting to do that. So our contribution to the Tumor Genome Atlas is to say, great, NCI, you go nuts with the tumors. We want to look at what's happening with perhaps the infectious, all the things that you're throwing out, we want to look at. So that's the first way you can start to look at this process. But then I think it actually gets even more interesting. So for our pathogen discovery project, one of our basic hypotheses is that when you look at all of these viral-associated cancers, their hallmark is that the tumor suppressors are wild type in these patients. So for instance, patients with Merkel cell, when they have the virus, have a normal P53, have a normal RB. But in the absence of the virus, the 10% of Merkel cell that are not related to Merkel cell polyomavirus have mutations in those. So that suggests that you can begin to look at one of two mechanisms. Either there's a host mutation or there's a virus. So certainly in any patient that has a cancer that you can't identify a classic somatic mutation, that's a problem. Then maybe there's an infection there. And those are the cases where we're looking even more closely to identify if there's another pathogen or another cause. But then once you do that, what I suspect you'll find is that there's an interplay. That what you'll find is that there are mutations, or that there are variants of host viral gene expression that interact with perhaps with the host genome that then cause a predisposition to the malignancy. So again, we don't know a whole lot right now, but my thought is that by bringing these two data sets together and these two disciplines together, we'll actually get the full picture. I don't think it's just the tumor genome or just the virome. I think it's probably a combination of both. Yeah.
Thanks very much, Dr. Casper. Thanks for coming.
Thank you.